All right, good morning, everyone. Welcome to Pediatric Grand Rounds. It's my pleasure to welcome back to the program Dr. Eric Vance. Dr. Eric Vance is currently an associate professor in child psychiatry at the Virginia Tech Carilion School of Medicine. In this capacity, he provides outpatient psychiatric care to children and youth at the Carilion Clinic and several other community-based mental health agencies. He is also the director of the medical school's clinical clerkship in psychiatry. His career started with 7 years of treatment and research in the North Carolina Willie M. program for aggressively mentally ill youths. After that program closed, he moved to New Hampshire for 13 years to work with the Seacoast Mental Health Center and eventually became part of the Dartmouth Trauma Intervention Research Center, treating and researching traumatized high-risk youths in the New Hampshire juvenile justice system. He has done numerous talks, trainings, and consultations for mental health systems, schools, and interagency groups in several states. His focus has been to promote the application of resiliency building and evidence-based therapies to intervene with high-risk youth. His research has been related to measuring and promoting protective factors and resiliency in youth with mental illness, delinquency, and traumatized population of youth. He has published several research articles and book chapters on resiliency. Please join me in welcoming Dr. Eric Vance.
Thank you, Dr. Permeshwar. It's my pleasure to be back with you again here at Pediatric Grand Rounds. I started preparing this talk as soon as I got the invitation and thinking about what I was going to present on, and then I realized with horror that I had a similar, very similar Grand Rounds 3 years ago, and I'm counting on the fact that many of the learners and have moved on, and so this will be a fresh set of learners, and many of the faculty will have forgotten what they saw 3 years ago, much as I've been forgetting things lately. But no, all jokes aside, I'm revisiting this topic with some fresh insights that I think you'll find timely, and with an added focus on the details of treatment and intervention, because I really feel that pediatricians are some of the most important frontline workers to begin to address and untangle the complicated effects of trauma in childhood, which is hugely prevalent in all of our populations. As we, in psychiatry, it's without question one of the most prevalent risk factors that we deal with in kids with any range of mental illness issues. And certainly in pediatrics, the effects of stress-related illnesses and trauma effects are extremely prevalent in the kids that you see. And it's worth beginning the journey to comprehensive treatment in the office of primary care providers, because you guys are on the front lines and you have so much access to the kid, the family, seeing them over time and beginning to address some of the impacts of trauma. So without further ado, we'll kind of dive in. I think it's worth starting with the definition of trauma, because I think some people feel as though perhaps the definition is difficult to pin down, but it's a rather broad definition in the sense we'll talk about today, simply because the range of environmental and experiential events that occur in the life of a child and a developing human are very, very diverse, as you'll see. And basically, we're talking about any experience or environmental impact that causes extreme stress with an enduring negative effect on the healthy development of a child. And healthy development of a child is kind of one of those things that you gain an appreciation for as you work with hundreds of kids over time and understand what norms are and so forth, but a lot of it's quite intuitive. But most commonly, when we think of trauma, we think of injury or extreme threats to a sense of safety in the developing organism. Anything that elicits a large fear response or significant pain, or even the perception of extreme vulnerability, or things like violation of trust, and that is trust in the things that protect the organism and protect the organism's healthy development, including, for example, the loss of protective loved ones, who are usually the first line of defense in a child's life in terms of protecting them from the kinds of dangers and stressors that a child might face periodically growing up. And even to the point where extreme threats to self-esteem, which, again, self-esteem is one of those psychological terms that is hard to pin down in some ways, but it just has connotations in this context to a person's overall sense of confidence and competence as they go through the world, and feeling that they're protected enough to engage in the process of healthy development, back to healthy development. And finally, in order to sort of qualify as a trauma, rather than just a sort of a temporary perturbation of the status quo in a person's life, we all go through stressors, often recover, often cope adequately. But when a stressor exceeds the sort of natural resilience that resides in most developing organisms, then there's an inability to fully and healthfully cope with it or recover from the experience in a healthy way. And that, more or less, in a nutshell, it leaves scars. Scars in the, whatever you want to call it, psyche. We now know that, scars, memories, and the kind of circuitry that gets disrupted in trauma effects can have lasting impact on the behavior, the cognition, the affect of the developing organism. So that's sort of the complicated but simple definition of trauma. So the common types of trauma are often some of the things that we all screen in a primary care setting. But my question to all of you is, do you screen enough? Do you screen deeply enough and broadly enough to capture some of the things that might have impacted some of the kids that we see? And, we all have limited time to screen for these things, but here's a long list to which I've added one significant thing that really all of us have had to either learn for the first time or remind ourselves of the intensity and profound impact of social and cultural oppression, such as things like racial violence and racial oppression in our society, or ethnic assaults on children that can happen as we've moved through this era recently of sort of the racial reckoning that we've had to make yet again in our country towards African American people in our culture, as well as some of the sort of hatred and trauma that's been imposed on Asian children and people as a result of the virus and myths about of how the virus came into our culture. And in a sense, we've all been traumatized and stressed beyond a lot of our abilities to endure just by dealing with the losses and the change in our lifestyles that have been imposed by dealing with COVID, which is sort of a what can be kind of categorized under a natural disaster or a man-made disaster in some sense. But otherwise, the list is fairly well known to most of us. But the importance is sort of finding for any child and for each child what was the particular thing that they've been through. And when I say they've been through, I feel like that's one of the most effective and compassionate ways that you can talk about trauma with a child or a parent in trying to gather your history. And one of the ways that I do it, just simply put, is asking a kid in my office, so, you know, little Johnny or Susan, if you think about your life growing up, what's the hardest thing that you've ever been through? And when you say been through, it accomplishes a number of things. It talks about the fact that they have in fact survived the trauma to be present here in your office in this conversation. And that in and of itself implies that they made it, that they figured out some way to survive. And even if they may have significant trauma effects as you assess them and talk to them, you're at least focusing on the fact that you are aware that they could have been through some really awful experiences growing up in their family or in their community or in their life growing up with big stresses of the kind that are listed on this slide, but they somehow survived. And it also opens the door for you to hear them talk about what's been the hardest thing for you in your life, while you also ask them a follow-up question that can be extremely helpful to them. What was it that you did that helped you get through all that? And you allow yourself to humble yourself a little bit to the child in terms of how they've coped and how their own sense of resilience helped them make it through whatever it is that they're sharing with you. So the impact of trauma in the general population is extremely prevalent. More than half of us will endure at least one major trauma on that list during the course of our lives. And so nearly everybody will be able to engage in that conversation that you just started by asking a kid what was the hardest thing that you've been through, or a parent, watching your child grow up and develop. Can you think of what the worst experience, the hardest experience might have been that they've had to go through, and whether it had any kind of lasting impact on them? That's a very efficient and simple way of asking, what can be an awkward question before you maybe provide a list of examples, such as any kind of physical or emotional abuse, or things that they've witnessed in the family or community, or things difficult and stressful, losses they've had, or things that they've had to endure in their life in a cultural or a social way that have stressed them. And of those half or more than half of us that go through trauma, about 1 in 3 of those people who go through traumas will develop full-blown PTSD. And we'll talk about the symptoms of that, which most of you are familiar with, but we'll review those. But beyond that 1 out of 3 who develop PTSD, there's also a range of other trauma effects that we see in humans and animals that affect them over the long term in terms of some neurobiological perturbations that I'll mention a little bit more as we go on. So some of those trauma effects that fall short of PTSD can include health problems, stress-related illnesses, for example, psychosocial problems such as problems in relationships and social development, as well as substance abuse disorders, which we know cause all kinds of problems. So, I like to say that trauma is not just for psychiatry anymore. And that's a, cute way of kind of handing over to all of you in your primary care offices some understanding that we now know that based on some important big longitudinal studies of adverse childhood events, we know that large studies have been done that have found that trauma in childhood predicted not only psychiatric problems and PTSD, but also drug and alcohol use, liver disease, early smoking, COPD, heart disease and stroke, depression, suicide, domestic violence, multiple sex partners, and the whole range of psychosocial and social problems that we all deal with. So the importance of everybody being as everyone who works with children standing as a sentinel to the impacts of stress going forward is obvious. So, what should pediatricians know about prevalences? These are from some nationwide surveys of children's experiences growing up. And it's some pretty sobering statistics about their exposure to violence and experience of violence. And this is just maltreatment and violence. You can expand these kinds of inquiries to include a range of different traumas. And if we begin to take awareness of, for example, exposure to the stresses of the COVID epidemic, for example, or exposure to racial oppression and bigotry and ethnic slights, those begin to expand the pool of traumatized kids to include almost every kid. When you start expanding your questioning about what a kid has been through, what are the hardest times they've been through, you begin to find that it's a rare kid indeed that really has not been through some sort of trauma that they can talk about. And it's always a useful discussion to get engaged in. And what I'll try to convince you as we go along is that the more you are willing to include this important line of questioning in your assessment, the more you're beginning the treatment and recovery from trauma by openly discussing it and acknowledging it. I'm including intergenerational trauma now in my talk about trauma for some very important reasons. One is it's been largely neglected in talking about trauma over the years that I've been involved in trauma treatment and trauma studies. It's really a type of trauma that's beginning to be explored scientifically, acknowledged socially and culturally, and really needs to be incorporated in our developmental view of the child as pediatricians, as child psychiatrists, and anybody who works with developing humans. One thing that we've, as traumatologists, if you want to call me that, as a psychiatrist or a therapist who deals with trauma, we've always been impressed by the number of parents of children that present with PTSD who themselves either have suffered with PTSD or been through significant trauma growing up. We more or less thought that was a sign of of stressful lives and stressed out families. But as we've begun to do animal studies to look at the mechanisms of transmission of trauma effects, we've discovered that there's some extremely important neurobiologic mechanisms of transmission that include epigenetic effects as well as intrauterine effects that can be passed from parent to child. For example, there's been a number of studies now of the offspring of traumatized people and animals, animal studies, experimental studies, as well as famine survivors and the offspring of famines and the Holocaust, and increasingly looking at the offspring of African American people who have been through racial oppression over time, and finding that there's a transmission of abnormalities in the HPA axis, the hypothalamic pituitary axis responses to stress that are measurable into adulthood in the offspring of people who've been through trauma or racial oppression, even into adulthood, and even if there's no sort of easily reported history of trauma in the offspring themselves. And it does explain a lot of what we've observed and the very difficult process of trying to heal, for example, a group of offspring of a group of people who've been oppressed or traumatized as a group, and explains the intergenerational transmission of racial trauma among Black and Native Americans and survivors of traumas that pass on some of the legacy to their kids, either by these intrauterine mechanisms whereby cortisol can pass through the placenta. We're finding also, for example, that parts of the placenta which are derived from fetal tissue can show differential effects of metabolism of cortisol at the placental level by the fetal tissue, almost as if the fetus is trying to protect or absorb the amount of stress that it's subject to across the placenta. So there's both maternal stress effects that can cross the placenta. There's fetal defensive or accommodation effects in the HPA axis and the metabolism of cortisol in the placenta. And then there's also methylation effects of the genetic material itself that can be handed from parent to offspring, even through the gametes, such that methylation, which we know to be one of the primary epigenetic mechanisms of the environmental experiences that allow turning on and off genes, methylation effects can be now, we know, transmitted through gametes from parents to the developing child. And it makes sense in retrospect. It explains a lot of intergenerational passage of problems and the effects of trauma. But it also makes sense from an evolutionary standpoint, insofar as these mechanisms of methylation and alteration of the HPA axis from parent to child intergenerationally may serve to prepare a human or an offspring organism to enter a certain stressful environment. So these signals of stress accommodation that a parent animal or organism or human passes on to their offspring likely assists in preparing the offspring for the stressors that they may have to face when they come into that environment. The symptoms of PTSD haven't changed in years, thankfully. A lot changes in our diagnostic criteria in psychiatry over time, but some things remain the same. There's three primary symptom domains, and the first is sort of what we often think about as re-experiencing flashbacks, memories, or in the case of children, often reenacting, or adults reenacting traumas that they've been through in their current lives and their current behaviors. A sort of repetition compulsion that can happen in some people that have been through trauma, whereby they end up placing themselves into traumatic situations, even by their brain's memory of what they've been through. On the other hand, you can have avoidance of the triggers rather than reenacting or re-experiencing or remembering. There's a sort of a shutdown of memory or avoidance of any cues or triggers or reminders, avoidance of interaction with people that were present or environments that you've experienced, and hyperarousal of the physiology, and this is where a lot of the neurobiological perturbations can be seen. There's activation of circuits that interact between the ventromedial portion of the brain, which is sort of the limbic and fear center of the cortex, and the amygdala, which is the emergency reaction system. These circuits get exacerbated by PTSD or dampened down, blunted by sort of overuse in traumatized people, as does the HPA axis with cortisol release and so forth, resulting in the whole range of physiologic disturbance of mood, sleep, anxiety, development of stress-related illness. I'm going to stop for a second to look at this chat question. Is it known if the genetic component is directly passed or a consequence of upbringing behavior by caregivers who had suffered these traumas? Well, it has been found that in some animal models and also in adopted away kinds of natural studies of humans, that there seem to be physiologic and genetic changes that exist in offspring irrespective of exposure to parental behaviors that might be sort of linked to PTSD. Now, but the caveat to that is one of the most profound observations about the intergenerational transmission of trauma effects has been the observation by many researchers over the last 100 years about the really extremely potent impact of a child, a developing child, a young offspring, observing an anxiety response in the parent, and particularly in mothers. Mother-infant, mother-child dyads in both humans and animals have been observed that if a parent has an extreme response to a trigger or a trauma of some sort, the child will very rapidly absorb that behavior and have a similar response to the parent, whereas they may not have had that kind of triggered response at all prior to observing the parent's response. And that's a phenomenon that's been labeled observed fear. And there's actually a researcher at VTCRI, Dr. Mazeroff, I believe I'm pronouncing that name correctly. He just presented at one of our case conferences a couple of weeks ago on his study of the effects of observed fear on animal models, where one animal observes another animal getting stressed or shocked, electrically shocked, and demonstrating the stress and the fear response, and then the observing animal that doesn't go through the shock will develop symptoms of PTSD simply by the observation of it. And this, of course, explains a lot of what we've observed in vicarious trauma, whereby children and any of us can listen to or hear about horrific traumas and absorb some of the awful kinds of effects of that into our system, and it literally impacts on synaptic development that lays the foundation for the development of PTSD. So Dr. Masaroff has observed that these unique and new synapses are formed during the experience of observed fear in animals that quickly will develop into the kinds of synapses that are consistent with PTSD in the circuits that are known to be involved in PTSD just by observed and vicarious fear. So that explains a lot about why it is so impactful for a offspring to observe in their parent a anxiety response. And so it really sort of lays the foundation for and sort of describes how it is that organisms can learn from the preceding generation what to be afraid of. And of course, after you've worked with trauma and looked for it and talked about it and the impacts of it with children and parents of children, you see that the range of impacts is very broad, and I sort of like this cutesy ABCs of trauma effects because it includes affective problems, behavioral problems that are common, cognitive problems that are prevalent, as well as the social problems that can develop, and somatic stress-related illnesses. And any and all of these symptoms can be either occur in the context of PTSD or simply non-diagnosable PTSD, but simply trauma effects. So some people get these isolated impacts of trauma that don't qualify technically as PTSD, but which are definitely trauma effects if you can establish the existence of trauma and then make a connection logically between that and the trauma effects. And this is the thing that's getting affected right here, and the hot spots are right at the ventromedial portion of the prefrontal cortex, which is that front part where you see the prefrontal cortex, and particularly those lower, or what's also called the orbital frontal cortex, right above the eyes, is where a lot of the fear circuitry exists and connects directly to the amygdala, which is sort of the emergency response system. And if you were at my talk a few years ago, you'd probably see this next slide, which is the stress response. And it's a complicated one with a lot of different ramifications. But suffice it to say that it extends to a lot of other brain structures and body structures that result in large physiologic and responses and neurochemical changes akin to what I just described that Dr. Masaroff has discovered that occur almost instantaneously, within the first 24 to 48 hours, you can have the development of what they call silent synapses, which are synapses that become ready to develop receptors that are highly responsive to an anxiety-provoking situation. And then the whole range of reactions and psychiatric symptoms that we target with medication, anxiety medications, antipsychotic medications, sympatholytic medications such as our alpha-2 agonists that we use, beta blockers. Those all target some of these receptors that we are faced with in the wake of trauma effects. Luckily, we have more than just medicine to throw at it, and that's what I want to get to. So the healing the brain from trauma really centers around the idea of breaking down how it is that trauma works. You'll notice that going back to the definition of trauma, where a lot of the traumatic experiences can be boiled down to perceptions that there is danger, perception that there is loss of protection, or inadequate protection available to the organism, and so those perceptions can go both ways, and that seems to be how our neurobiologic and autonomic nervous system is arranged. We're arranged to have the sympathetic nervous system on the one hand, which is extremely sensitive to the perception of danger, as evidenced by that previous slide. And on the other hand, though, there is a side to our physiology and our neurobiology that actively seeks safety, the perception of safety, the opposite of the perception of danger. And our nervous systems are designed to promote both physiologic states, generally not simultaneously. Occasionally simultaneously, which can create extremely complicated trauma effects when, for example, a organism gets traumatized by another organism that is supposed to be their provider of safety, such as child abuse, which mixes that perception that this person is supposed to be protecting and making you feel safe, but instead they're causing you trauma and danger. But in general, in a healthy organism, we toggle back and forth between the perception of danger and the perception of safety. But in healing trauma, in beginning the process of taking a traumatized person or child, starting down the path of healing, one of the most important things that can be established is a perception of safety. And this is, our brains are designed in the parasympathetic side to identify what is safe. And this pertains not only to individual organisms in the developmental process, but also to children on a social and cultural level. As you can imagine, our society, our institutions, our hospitals, our schools, our clinics need to be conscious of the need for a perception of safety in order to begin to heal pervasive trauma effects in different populations. And as I had emphasized earlier, in a very simple way, acknowledging what people have been through, with the been through part, acknowledging both it was a very hard thing, but also they made it through, implying that they manage to exert some sense of resilience. And then, educating people about trauma, knowing the intergenerational effects of trauma, acknowledging that usually when we're interacting with a traumatized child, we also have access to another generation of people, and that's the parents or the grandparents, to acknowledge and educate about the impacts of trauma effects as it marches down through the generations. Learning and teaching the ABCs of trauma effects, acknowledging the broad range of trauma effects, and providing this education in primary care offices doesn't take necessarily as long as you think it does, and just acknowledging the profound impact is a great relief to a lot of people who are struggling with trauma effects, so that they don't feel as though they're crazy. In the long run, when you attempt to heal trauma in the brain, you have to get the person to be able to tell the story or relate the story, to bear witness, and also to help them desensitize to the impact of the trauma. And finally, building resilience factors that we've come to understand that range from helping people learn to calm their nervous system and toggle away from sympathetic arousal and more towards parasympathetic stimulation, which includes being in safe places, having enjoyment, sharing love from protective relationships. And so all of the things that get aroused by the parasympathetic nervous system include the things we think of as relaxation, anti-stress, being loved, being cared for, feeling safe, allowing metabolic and growth and healthy development to occur. So there is this whole other side of the brain that perpetuates parasympathetic arousal, and that involves the ventral vagal complex, and it ties into the social engagement system, so that rather than fearful and threatening kinds of facial expressions that get elicited by the sympathetic system, you instead get positive, smiling, engaging kinds of facial expressions and use of the cranial nerves that are in the parasympathetic side of things that get stimulated through this afferent perception of safety. So a lot of what we do in treatment is try to help people to immerse their brains and bodies and habits in promoting parasympathetic tone and decreasing sympathetic tone. And there's some known protective factors that sort of play into all of these kinds of protective factors and the kind of arousal of the parasympathetic and the diminishment of sympathetic arousal. And it ranges from trusting and warm relationships, finding those things for the traumatized person, which may mean transforming a traumatized relationship to a warm and trusting and positive relationship, which is a lot of what we do in sort of parent-child work in trauma treatment. Establishing, predictability and the perception of safety and these positive catabolic, metabolic kinds of pro-metabolic types of physiologic activities, as opposed to catabolic mechanisms that act through the sympathetic arousal. And then helping people to discover problem-solving techniques and things like meditation and journaling and reading and activating the cortical activities that can reach down and generally calm the limbic system of a traumatized person. So these sort of well-known protective factors all have foundation in the parasympathetic nervous system and diminishment of the sympathetic tone, and therefore make transformations in neurophysiologic pathways. It diminishes some of those trauma circuits that I alluded to, and begins to transform things in a positive direction. I'm going to have to wrap up, so I leave some time for questions. But these are some of the brain mechanisms that and neuro pathways that you have to access during the course of trauma therapy. And in a practical sense, trauma therapy consists of these components. This is trauma-focused CBT, or cognitive behavioral therapy, and it starts with psychoeducation and teaching parenting skills that are sort of non-traumatic. And so you'll see the role of the PCP is in psychoeducation and acknowledging the impact of trauma. It also has to do with teaching relaxation and affective modulation, helping people to engage in cognitive processing that kind of counteracts some of the cognitive distortions that can arrive in a traumatized life. It always includes allowing and encouraging the trauma narrative of a person who's been through trauma that actually accomplishes desensitization to the triggers of that trauma if you engage in it in a thorough and comprehensive way. The best trauma therapy involves conjoint parent-child sessions, which, as we've discussed, involves and incorporates intergenerational constructs of trauma. And then in the long run, just the promotion of safety, a perception of safety, and resilience factors in the kid's life are going to be the best medicine for healing trauma. And so this is sort of how these trauma therapy components work in the brain, two ways: top down, from the cortex, talking about trauma, telling the story, journaling about it, learning how to calm your cortex so that it can reach down and calm the limbic system, and then bottom up types of interventions that work through the body, encouraging good, healthy circadian rhythms in the person's life, which stabilizes their physiology and works sort of from a bottom-up process, teaching meditation, doing yoga, doing exercise, engaging in hugging behaviors, pro-social interactions, works to take the organism from the sympathetic arousal system to the parasympathetic arousal system, and in that way kind of counters the trauma impacts from the bottom up, or the physiology, to the cortex. And that's the end of my talk. I've exceeded my time, but I hope I left a little time for questioning.
Okay, sounds good.
There's a question here. Do you have specific techniques for a traumatic relationship to be resolved, and how many of these types of relationships can effectively be resolved? Traumatic relationships, usually we're finding out, as I've alluded to, involve intergenerational experience of trauma. It's rare for a traumatic relationship to arise without the traumatizer or the apparent traumatizer having been through trauma themselves. And one of the things that you find out quickly if you start working with traumatized kids is that you can't avoid working with the traumatized parent. And a lot of people make the mistake of thinking, I'm going to go into pediatrics so I can work with kids because working with parents is too hard, or child psychiatry, same way. I love working with kids, but if I could just get the parent out of the room, everything would be fine. What you end up finding is that the greatest satisfaction comes from helping the parent to understand maybe the trauma they've been through and how that's causing them to possibly traumatize their kid. And most 99.9% of parents want to do a better job at raising their kid. That's their genetic material. That's their, legacy here in the evolutionary chain. And the greatest instinct is they want to do better. They may not know how to because of the trauma they've been through. So until you kind of address and acknowledge the trauma that a parent's been through and they understand the impacts on themselves, that can be the most powerful tool in having them resolve the traumatic relationship with their kid.
I did find the other slide that the questions were, which of the following statements are true? A is only 1/3 of children will develop PTSD after major trauma. B, over half of children with PTSD have a parent with PTSD. C, over 1/3 of all women have been through sexual abuse. D, all of the above. So if people could answer that in the chat, we'd appreciate that answering that question. Would that be the correct answer for the first question, Dr. Vance?
Yeah, that's the correct answer. I don't make my tests very hard.
And the second one is treatment of trauma effects. Is it A, starts with education about trauma effects, B, may include talking about racial injustice, C, can include prayer, yoga, or joining the football team, or D, all of the above? If you all could answer that question too, please. And would that be the answer for the second question, Dr. Vance?
Yes, I can't believe I made it so easy. If I ever give yet another talk about trauma and treatment, I'll make it just a lot harder on the test. The